The procession is about to commence. Once again, I want to welcome you all formally to the 106th Inaugural Lecture of this great citadel of learning, to be delivered by a distinguished Professor of Community Medicine from the Department of Community Medicine and Primary Care, Faculty of Clinical Sciences, Obankemi Awolowo College of Health Sciences. Many other persons are distinguished Professor OLUSOJI, James, Daniel. The topic of this inaugural lecture is the Great White Plague: Money, Power, Politics, and Public Health. Distinguished ladies and gentlemen, the procession is being led by the Acting Dean Student Affairs, Dr. Maruf Oladimiji. It's closely followed by the Acting Dean, Faculty of Engineering, Dr. Abayomi Layeni. Dr. Abayomi Layeni is followed by the Dean, Faculty of Agricultural Management and Rural Development, Professor Diran Awotide. Next to him is the Dean, Faculty of Arts, Professor Samson Dari. Professor Dari is followed by the Dean, Faculty of Pharmacy, Professor Latif Saka Kasim. Of course, he is followed by the Dean, Faculty of Clinical Sciences, Professor Mrs. M.B. Betuga. The clinic department, the Faculty of Clinical Sciences is producing the inaugural lecturer for today. Please take note of that. Next to her is the Dean, Faculty of Basic Medical Sciences, Professor Mrs. Omobola Ogundansi. She is closely followed by the Dean, Faculty of Science, Professor Lawrence Adebayo. Professor Adebayo is followed by the Acting Dean, Faculty of Law, Dr. Wade Akinrimade. Next to the Dean, Faculty of Law is the Dean, Faculty of Education, Professor Olufemi Kalesanwo. Professor Kalesanwo is of course, where does the money goes? The Dean, Faculty of Administration and Management Sciences, Professor R.O.C. Shomoye is the next person. He is closely followed by the Provost, College of Agricultural Sciences, Professor Adewale Onosoya. Of course, before Professor Adewale, we have Studies, Dr. Bashir Odubuwa. Professor Odubuwa is followed by the Provost Obafemi Awolowo of Health Sciences, Professor O.C. Eko Olatunji. Next to him is the Provost, Postgraduate School, Professor Olusegun Adebayo Awal. It's closely followed by Mr. Semiu Makinde, who is currently University Bosa. And of course, the University Registrar, Mr. Femi Ogunmoju. Next to Mr. Femi Ogunmoju is the Deputy Vice Chancellor of Administration, Professor Charles Olufemi Adekoya. Next to him is the Deputy Vice Chancellor of Academic, Professor Olatundu Abosede Oderinbe. And of course, the inaugural lecturer of today, Professor OLUSOJI, James Daniel, is being honored by our own Vice Chancellor of the Great University, Professor Ayodeji Agbola. Can we give them a round of applause? Thank you, ladies and gentlemen. Shall we have our seat? Vice Chancellor other distinguished personality at the high table, distinguished member of the audience, I now have the pleasure in inviting the registrar of this great university, Mr. Femi Ogunwomoju, who in turn will invite the Vice Chancellor of this great university, Professor Ayodeji Agbuola, to declare this professorial inaugural lecture open. Thank you very much, Mr. Registrar, sir.
Distinguished ladies and gentlemen, may I please invite the Vice Chancellor, Professor Agbuola, to please declare this 106th inaugural lecture open. The Vice Chancellor.
Principal officers of the universities, deans, provosts, professors, here present, head of departments, members of Senate, other distinguished members of the university community, I invited guests on behalf of the Senate of this great university. I hereby declare 106 inaugural lecture of today open.
May I again ask the Vice Chancellor to please introduce the inaugural lecturer of today, Professor OLUSOJI James Daniel. Vice Chancellor, sir.
Distinguished ladies and gentlemen, I have the pleasure to introduce the 106th inaugural lecturer of today in person of Professor OLUSOJI James Daniel. He was born on 15th April 1971 in Ikeja, Lagos State. Completed his elementary education at the Nigerian Air Force Primary School, same Ikeja, Lagos in 1881, and secondary school education at the Nigerian Air Force Secondary School, Ikeja in 1986. Thereafter proceeded to the Kwara State College of Education, now Kwara State Polytechnic in Ilorin, Kwara State, for his advanced level studies. And in 1989, he gained admission into the University of Ilorin, Kwara State, to study medicine. He graduated with a Bachelor of Medicine at the University of Ilorin Teaching Hospital in the year 1995. He also completed his one-year scholarship program at the same teaching hospital in 1996. And thereafter proceeded to Katsina to observe 1 year National Youth Service Corps, during which he served at the Primary Healthcare Center, Safana, in Safana local government area of the Katsina State, in the year 1996 to 1997. He thereafter again practiced as a medical officer briefly in private hospitals and also at the General Hospital, Share, in Kwara State. Poised to have a niche in the field of medicine, Professor Daniel immediately commenced his residency training program in community medicine at the Ogun State University Teaching Hospital, now Olabisi Onabanjo University Hospital, Shagamu, in the year 1998. He completed his training in April 2003 and was awarded Fellow, West African College of Physicians in the Faculty of Community Medicine. His quest for academic excellence took him to the College of Medicine, University of Lagos, where he obtained Masters of Public Health. He also got a Master of Science, Business Administration from the PLAQUE Institute of Technology, Sweden, in the year 2008, and a PhD in public health from Lancaster University, United Kingdom, in the year 2017. The inaugural lecturer joined the service of the Ogun State University, now Olabisi Onabanjo University, as lecturer 1 and consultant physician at the Olabisi Onabanjo University Teaching Hospital in the Department of Community Health and Primary Care in the year 2004. By dint of hard work and dedication, he rose through the ranks to become the first professor of community medicine produced by this great institution in 2017. This resourceful researcher of proven track record won the Arthur Ashe Fellow in Clinical Management of HIV Disease at the New York Hospital in October 2002, facilitated with a scholarship from the same endowment for the defeat of AIDS, also in 2003. He also won a fellow Academic Alliance for AIDS Care and Prevention in Africa, Faculty of Medicine, Makerere University, Uganda, in November 2003, with another scholarship from Infectious Disease Society of America, IDSA. He won yet another fellow of the Royal Society of Public Health, UK, in the year 2010, followed by a certificate in building, design, and engineering approach to airborne infection control program, Harvard School of Public Health posting in USA in August 2012, with a grant from the Center for Disease Control, CDC, Atlanta, USA. He was equally awarded a fellow of the Medical College of Public Health by the National Postgraduate Medical College of Nigeria in 2018. Apart from teaching various courses in his area of specialization, at both undergraduate and postgraduate levels, he has served the university methodically in different capacities. He was the acting head of the department between 2014 and 2016, member College Curriculum Committee 2014 to 2016, MPH Coordinator 2016 to 2017, Head of Department 2018 to 2021, member Talabi Research Center, and many other committees in the Faculty of Medical Sciences, as well as Obafemi Awolowo College of Health Sciences. A researcher of repute and academic by excellence, Professor Dane has to his credit over 100 publications in peer-reviewed journals, both locally and internationally. He has attended and presented in several professional conferences, both at home and abroad. He has successfully supervised several undergraduate projects, Masters of Public Health thesis, doctoral degree thesis, and postgraduate fellowship dissertations in community medicine to public health, both within and outside the university. In recognition of his professional dexterity, Professor OLUSOJI has been nominated to serve as an examiner to the West African College of Physicians, external examiner to the Lagos State College of Medicine, as well as Babcock University in Ishorema. He has provided technical assistance to several organizations, including World Health Organization, Diamond Foundation Nigeria, KNC VTB Foundation Nigeria, the National Tuberculosis and Leprosy Control Program, and the National HIV/AIDS Control Program. He currently serves as the pioneer chairman of Tuberculosis Operational Research Technical Working Group of the National Tuberculosis and Leprosy Control Program of the Federal Ministry of Health. Professor OLUSOJI belongs to notable professional bodies and learning society, such as the Association of Public Health Physicians, the Royal Society of Public Health, UK, Medical and Dental Consultants of Nigeria, Nigerian Medical Association, Epidemiological Society of Nigeria, and the International Epidemiological Association. Finally, he's happily married to his lovely wife, Dr. Bolanle Temitope Dani, and their union is blessed with children. Ladies and gentlemen, please join me in inviting the inaugural lecturer of today to the podium. Professor Daniel, over to you.
The Vice Chancellor, the Deputy Vice Chancellor, Academic, the Deputy Vice Chancellor, Administration, the Registrar, other principal officers of the university, Provost of colleges and the postgraduate school, Deans of faculties, fellow distinguished professors and heads of departments, my teachers, distinguished colleagues, family and friends, gentlemen of the press. Great OUIs. Mr. Vice Chancellor, sir, 19 years ago, when I walked into this institution, I never imagined I'll be standing before you all today to deliver the 106th inaugural lecture titled The Great White Plague, Money, Power, Politics, and Public Health. We are here today to witness history, as this is the first inaugural lecture from the Department of Community Medicine and Primary Care since the inception of Olabiso Onabanjo College of Health Sciences, Shagamu, about 37 years ago. And while I was preparing for this lecture, I cannot but reflect on how I got here. In the concluding days of my secondary school education, some colleagues asked me what my future career paths would be. I remember saying business administration, and my first JAMB was a testament to that. However, I had a turning point when I got to Ilorin for my advanced level degree at the then Kwara State College of Technology, Kwara Tech. During my registration, I looked at the course requirement for studying business administration, which was my preferred course, and found that I had to take mathematics as one of the subjects. I instantly changed my mind. I went for physics, chemistry, and biology. The fear of mathematics drove me to pursue a career in medicine. And Proverbs 16:33 says, "The Lord is cast into the lap, but the decision is wholly of the Lord. Even the event that seemed accidental were ordered by Him." That sums up my story. Towards the end of my NYSC in Katsina, I was convinced that God wanted me to pursue a career in community medicine. And on my way from Katsina, I branched off at Ilorin, where I met some of my teachers who asked me about my next career choice. When I told them I would specialize in community medicine, they were all puzzled. Well, community medicine was not that popular, and they called me Wole Wole, sanitary inspector. In which I responded, "I'm the chief of the Wole Woles. I'm the chief sanitary inspector." That same year, I passed the West African College of Physicians primary exams in community medicine, and that officially signaled my entrance into a lifelong specialty and career. I was offered an appointment as a resident doctor in the Department of Community Medicine and Primary Care, Olabiso Onabanjo University, in the year 1998, when Dr. F. Oluwole was the Chief Medical Director and the late Dr. Idowu was the former registrar of the Medical and Dental Council of Nigeria, was the head of the department. Mr. Vice Chancellor, sir, the foundation for a lifelong academic career and research into the Great White Plague started with my interaction with the foundation head of the Department of Community Medicine and Primary Care, former provost of Obafemi Awolowo College of Health Sciences, and the former chief medical director of the then Ogun State University Teaching Hospital, Professor Olanipekun Camille Alausa. He asked me to bring, and my mentor is here. He asked me to bring topics I plan to do for my battle dissertation for the West African College of Physicians Fellowship Examination. After sharing his experience as a pathologist, medical microbiologist, and an epidemiologist with me, I decided to invest my time studying this disease. Before I continue, I want to reiterate the purpose of an inaugural lecture. First, it allows academic scholars to inform the university community and the public of their scholarly activities and contributions to the body of knowledge. Second, it allows the scholar to update the university community on the researcher's current and future scholarly agenda and academic direction. Mr. Vice Chancellor, sir, this inaugural lecture draws from my gown and town experience. My gown experience will reflect on my scholarship activities in my specialty of community medicine. As an epidemiologist, my town experiences include programmatic experiences interacting with 5 prominent international organizations: the Center for Special Studies, Shagamu; Center for Research in Reproductive Health, Sierra Ridge, Shagamu; Family Health International of the Green Project, Damian Foundation, and the World Health Organization, where I worked in both the HIV and the TB program. In addition, my job description allowed me to interact closely with government, the Ministry of Health at all levels and its agencies, namely the National AIDS and STI Control Program, NASCAP, the National AIDS Control Agency, NACA, and the National Tuberculosis and Leprosy Control Program. This myriad of experiences reflect my topic today, the Great White Plague: money, power, politics, and public health. Mr. Vice Chancellor, sir, the Great White Plague was the term used to describe tuberculosis epidemic in Europe at the beginning of the 17th century that was unrelenting for about 200 years. TB caused considerable morbidity and mortality, especially in the lower socioeconomic class of society, and was the leading cause of death in Europe. At that time, the annual mortality rate from TB were between 800 to 1,000 deaths per 100,000 population per year. For example, between 1851 and 1910, 4 million people died from tuberculosis in England and Wales. About a third of the deaths were among the age group 15 to 34. Then tuberculosis was referred to as the robbers of youth. Similar death rates increased rapidly in America and peaked at 9,000 deaths per 100,000 population in 1886, as shown in the diagram below. The term white plague was first used by Oliver Wendell Holmes, an American physician and writer, in 1861, while comparing the enormity of TB epidemic and its attendant mortality to similar severe plagues of the time, such as the bubonic plague and smallpox. Domande 1999 states that whites may have referred to the association of TB with youth and innocence, while others use the term white to describe the extreme anemic pallor associated with those infected with the disease. As called then, the consumptive patient took a delicate, pale, melancholic appearance. Some poets described the wan and pallid faces of those affected as attractive, incredibly, because some wealthy women were involved. Domande wrote that the disease gave women a terrible beauty. Mr. Vice Chancellor, sir, TB, however, is an ancient disease with a long history that predated the 18th century. This condition dates to biblical times, with 2 instances where TB disease got mentioned in the Holy Book, the Bible. These were Leviticus 26:16 and Deuteronomy 28:22, where the word plague was used in both instances and translated as consumption in both the King James and the Revised Standard Version of the Bible, which dates back to 1611 and 1901, respectively, when consumption was a word commonly used to refer to tuberculosis. The name tuberculosis as we know it today first appeared in medical language in connection with gas. Tuberculosis for the first practice. The name was first called by Professor Joan as the disease associated with tuberculosis. However, it was not until 1882 that Robert Koch, 1843 to 1910, identified the Bacillus mycobacterium as the cause and the trustworthy agent of tuberculosis. And the reason why the World TB Day is celebrated on that day every year is to educate the public about the disease, its measures to eliminate the disease. Mr. Vice Chancellor, sir, tuberculosis is a chronic infectious disease caused by Mycobacterium tuberculosis. About 1/3 of the world population is infected with TB. Globally, TB is one of the top 13 causes of death. And due to the COVID-19 pandemic, TB is now the second leading infectious killer after COVID-19. It is also the leading killer of people with HIV and a significant cause of death related to antimicrobial resistance. In 2021, an estimated 10.6 million people fell ill with TB worldwide, of which 6 million people were men, 3.4 million were women, 1.2 million were children. Globally, the estimated number of deaths from TB increased between 2019 and 2021, reversing years of decline between 2005 and 2019. In 2021, 1.6 million people died from TB, including about 200 people with HIV. TB is transmitted by the airborne inhalation of infectious droplet nuclei produced by an untreated pulmonary TB patient while talking, coughing, sneezing, or singing. A single cough can produce 3,000 infectious droplet nuclei. Within 2 to 8 weeks, special immune cells called macrophages ingest and surround the tubercle bacilli. The cells form a barrier called a granuloma that keeps the bacilli contained and under control. These small droplet nuclei can avoid the bronchial defenses and reach the lungs alveolus, where multiplication and infection can occur. Tuberculosis primarily affects the lungs, pulmonary TB in about 80% of cases. Still, it can affect any other organ when the bacilli enters the bloodstream and spread to other organs, including the bones, the skin, the brain, and the vertebral spine. The most typical symptom of TB is a cough for more than 2 weeks or more, which is usually accompanied by fever, weight loss, night sweats, chest pain, shortness of breath, tiredness, loss of appetite, and hemoptysis. Extrapulmonary TB presents symptoms based on the organ affected, in addition to general symptoms such as tiredness, weight loss, fever, and night sweats. Diagnosis of TB is made by examination of the sputum using gene experts and other molecular and microbiological tests such as AFB, microscopy, and culture. A person with active TB can infect 10 to 15 persons in a year through close contact. If TB is left untreated, 70% of smear positive, HIV negative patients will die within 10 years, while 20% of untreated, smear negative, culture positive TB cases will die within 10 years. Though the disease is treatable and curable with a standardized treatment regimen for 6 months, the disease remains a significant public health problem in the country. We carried out analysis of TB in Nigeria using case notification data from 2012 to 2015 and found that more males were affected with TB, and there exist differences in the peak age at diagnosis. The peak age for women was in the age group 25 to 24, compared with men 45 to 54 years. This suggests differences in the risk of infection between both sexes, as shown in the diagram below. The states with the highest case notification rates include Benue State, Nasarawa State, and FCT. Mr. Vice Chancellor, sir, wealth, money, and poverty are on opposite sides of the economic spectrum. However, there is a relationship between wealth and health. Poverty leads to poor health, and poor health, in turn, leads to poverty and low productivity. And if unchecked, the vicious circle continues unabated. The World Health Organization estimates that poverty-related diseases account for 45% of disease burden in the poorest countries. These diseases are, however, either preventable or treatable with existing medical knowledge. These diseases include tuberculosis, malaria, and HIV/AIDS, which account for nearly 18% of the disease burden in the poorest countries. The World Bank described extreme poverty as income level below $2.15 per person per day, which is the required to meet the minimum basic need of an individual. Well, with inflation today, I think that no longer holds. The United Nations in 1995 took a multifaceted approach to poverty, stating that it has various manifestations, such as lack of income, unsustainable livelihood, hunger, and malnutrition, ill health, and limited lack of access to education and other essential services. Also, increased morbidity and mortality from illnesses, homelessness, inadequate housing, unsafe environment, and social discrimination and exclusion. It is also characterized by lack of participation in decision-making and civil, social, and cultural life. This definition emphasizes the multidimensionality of poverty over and above lack of money or income. Mr. Vice Chancellor, sir, tuberculosis is a disease of poverty. The relationship between TB and poverty is a vicious circle. Poverty is a predisposing factor to TB infection, while TB infection causes untold economic hardship for affected individuals, families, and communities, especially the poor. The effect of poverty on TB can be seen at different levels. At the country level, we carried out a study on the spatial inequality of tuberculosis in Nigeria. We found an inverse relationship between TB case notification and the GDP, the gross domestic products per capita of states in Nigeria. The study showed that relatively poorer states have higher TB case notification rates. At the individual level, poor people are likely to be malnourished because of poor feeding habits, live in poor unhygienic environments where TB flourishes, and are likely also to live in overcrowded homes that facilitate the transmission of the disease. Even after the disease, poor people are more likely to encounter barriers to accessing health services and therefore have disproportionate poorer health outcomes. The disparities in the socio-economic situation of people and other structural factors in societies, that is, where people are born, develop, live, and work, are responsible for the differences in the risk of exposure, vulnerability, progression from from TB infection to disease, and the ability to recover after being ill with TB. People affected with TB have associated social and economic consequences because of the disease. Each year, about 100 million people are forced into poverty because of TB disease. TB affects the household financial situation of patients through out-of-pocket payment for hospitalization, diagnosis, treatment, and care. TB patients are also faced with indirect and opportunity costs related to time lost from work due to healthcare seeking, transportation, poor work capacity of the sick patient, and outright loss of employment. In addition, family members and caregivers also bear some of the financial costs for caring for their sick TB relatives. Power. Mr. Vice Chancellor, sir, the World Bank in the year 2000 published a classic book titled The Voices of the Poor. Can anyone hear us? It describes that poverty includes poor economic well-being, vulnerability, powerlessness, and social isolation. Besides being a poverty disease, TB clearly shows the unequal distribution of power and resources between wealthy and low-income countries. The TB incidence and death rates have declined mainly in high-income countries, yet TB remains a significant public health problem in many developing countries, where 95% of deaths occur. Globally, low and lower middle-income countries, where 76% of the world population live, accounts for more than 90% of TB cases and deaths. These countries neither have the economic resources nor the technical capabilities to handle the epidemic proportion of the disease. It highlights the imbalance of power due to the lack of resources that affects the distribution of diseases within countries. Without resources, developing nations have no voice when decisions are made. At the individual level, powerlessness is manifested when the body cannot defend itself against the ravaging onslaught of the bacteria. Because, for example, persons vulnerable to TB include children, persons living with HIV, and diabetic patients. TB in children and adolescents. Children are particularly susceptible to TB because of their immature immune system. An estimated 1 million children under 15 years fell ill with TB. 205,000 died, and TB orphaned 10 million children in 2018. However, only 40% of the estimated 1 million children with TB were notified by the national TB programs. From our experience in Lagos, only 6 to 7.5% of the total case notification are children, which is about half of what is expected in a high-burden country like Nigeria. It suggests that even though children are susceptible to TB infection, they are not diagnosed and notified, mainly because of diagnostic challenges or due to lack of an index of suspicion on the part of the healthcare workers. The comorbidity of HIV compounds TB in children with devastating effects. Our study shows that TB-HIV comorbidity in children ranges from 10.5% to 29.2%. Children have no voice except we speak on their behalf for the provision of better diagnostic tools that will help detect TB earlier and child-friendly formulation that will help in the treatment of TB, thereby reducing TB mortality and the untold hardship experienced by their families. TB and HIV. There exists a synergistic relationship between TB and HIV. HIV disease destroys the body immune system. Therefore, it makes the body vulnerable to TB infection, which is why TB is the most common opportunistic infection among HIV positive patients. In our study, we found that factors associated with having TB-HIV co-infection include age over 40, extrapulmonary TB, and TB patients who were treated. The study also found that TB-HIV co-infection was associated with poorer TB treatment outcome, leading to retreatment of the disease in HIV-positive patients. In addition, the HIV epidemic has also been associated with an increase in the number of non-tuberculosis mycobacterium diseases in the country, which do not respond to the available conventional anti-TB medicines and cause increased mortality among TB-HIV co-infected patients. TB and undernutrition. There is a synergistic relationship between TB and undernutrition. Undernutrition predisposes an individual to TB, while TB infection worsens undernutrition. Our study found an inverse relationship between body mass index and the prevalence of TB in Nigeria. A modeling study that we did suggests that up to 71% of new TB cases can be removed from the population if undernutrition as a risk factor is removed. To eliminate the TB epidemic risk factors such as undernutrition, HIV, low BCG coverage, and poverty needs to be addressed as shown in the figure below. Politics. Mr. Vice Chancellor, sir, the political setting of a nation or country determines the health condition of the people. The cause of ill health for millions globally are rooted in political, social, and economic injustices. This is because the political system determines the health policy, resource allocation, workforce policy, and the quantity and quality of health services available and accessible by the community. The political environment, therefore, plays a critical role in how the social policies and the health system affect the success or otherwise of public health intervention. Evolution of the TB strategy and policy. In 1994, the World Health Organization adopted and launched the Direct Observed Treatment Short Course strategy as the key global strategy for controlling TB. This call puts TB control high on the international public health agenda. It recognized short course chemotherapy as one of the most cost-effective health interventions. The DOT strategy was revised to the Stop TB strategy in 2006 to address the identified challenges in implementing the DOT strategy. WHO estimated that 53 million lives were saved by implementing the DOT strategy between 2000 and 2018. The success of the DOT strategy was also demonstrated in our own study in our clinic in Shagamu, which showed that the patients treated under the DOT program had better treatment outcomes and reduced mortality compared with patients that were treated in non-DOT situation. TB policy and private health sector. Private healthcare provider accounts for about 60% of the health expenditure in Nigeria. One of our studies showed that private health providers not under the government treatment program in Nigeria are known to diagnose and treat TB patients inappropriately, which has often led to poorer treatment outcomes. Another study we did showed the importance of engaging private health facilities in delivering TB services. TB patients treated in private facilities under the government program experienced lower health system delays than those treated in public health facilities because private health facilities were accessible and offered better personalized care. In another study, we concluded that private health providers were viable partners in improving case finding during industrial strike actions in the public health facilities. In another study, we found that the treatment success rates among patients that were managed in private health facilities were similar and sometimes even higher than those in the public sector. Furthermore, our study found that private facilities were responsible for 10.3% of the total TB case notified in Lagos, suggesting that the private sector's potential in TB control is yet to be fully tapped into by the National TB and Leprosy Control Program, needing further strategic engagement of the private health sector in the TB treatment network. It is beneficial to uncover the missing cases of TB in the country and support the private sector in providing TB diagnosis and treatment services that will improve accessibility to TB treatment, especially in poor communities. Financing for TB control. Mr. Vice Chancellor, sir, a nation's health budget signifies the government's policy direction and priorities. However, in the last 9 years, the allocation to health has been consistently below the 15% set by the 2000 Abuja Declaration. In 2019, the health budget accounted for 4.1% of the total budget, which does not translate in many occasions to budget release. In addition, the rising inflation rates, corruption, and the high recurrent expenditure of over 80% have adversely affected the development of the health sector. The World Health Organization estimates that 72.9% of the country's current health expenditure is out of pocket. These out-of-pocket payments are direct payments made by individuals to healthcare providers at the time when they make use of the health service. These payments constitute access barriers to needed services and further pushes patients and their families into catastrophic and impoverishing health expenditure. The government's funding commitment to fighting the scourge of TB in the country over the years has been limited. From the figure above, about $278 million were needed for TB control in the country in 2019. Domestic funding accounts for only 8%, international donors for 32%, and about 60% remains unfunded. As a result, many programs, activities to control TB in the country could not be carried out due to lack of funding. The interaction between money, power, politics on TB control, Mr. Vice Chancellor, sir, the persistence of poverty and social and political factors underlying the epidemiology of the disease have led to increase in TB morbidity and mortality, and more importantly, to the increase in the burden of drug-resistant TB with its attendant consequences in the country. As Nelson Mandela said, as long as poverty, injustice, and gross inequality persist in our world, none of us can truly rest. This statement was true then as it is today. Public health or community medicine, my colleague. Mr. Vice Chancellor, sir, it is a thing of joy and pride to be called a community physician, and nothing gives greater joy than adding value and making a positive impact in the lives of patients and the numerous healthcare workers I have met in my life's journey and career. Before proceeding, I would like to clarify the misconception of interchangeably using the terms public health, preventive and social medicine, community health, and community medicine. According to WISLO, public health is defined as the science and arts of preventing disease, prolonging life, and promoting physical health and efficiency through organized efforts and informed choices of society, organizations, public and private communities, and individuals. Public health, therefore, is an interdisciplinary approach that encompasses a broad group of health professionals with a common goal of preserving, promoting, and maintaining the public's health. Community health shares the same goal as public health, except that is organized around a geographical area, focusing on prevention, promotion, curative and rehabilitative healthcare to people in a defined geographical area. The defined geographical area could be a local community, could be the local government, the state, or the entire country. On the other hand, community medicine can be regarded as an aspect of community health that is the exclusive preserve of a physician within the context of public health practice. In the 70s in Great Britain, the term community medicine described a branch of medicine concerned with population or groups rather than with individual patients, requiring special knowledge of epidemiology, organization and evaluation of healthcare, and medical care, and the medical aspects of health service administration. Thus, community medicine is nested within both public health and clinical medicine and can be regarded as the vital bridge between the two. Epidemiology. Though the specialty of community health has about 13 subspecialties, my primary area of interest is epidemiology. Epidemiology is the bedrock of public health and is focused on preventing disease in population as a whole, in contrast to the other clinical sciences that focus on disease pathology and treatment of individuals. Last, in 1998, defined epidemiology as the study of distributional determinants of health-related states amongst specified populations and the application of that study to the control of health problems. Epidemiology describes disease distribution in terms of the who, the where, and when. It describes the risk factors of disease causation and the effectiveness of intervention to avoid the problem. Epidemiology provides evidence for public health decisions, policies, and interventions, and eventually evaluate whether such interventions work. In the years of being involved in clinical research, I have applied epidemiological principles in the areas of clinical research, clinical epidemiology, social epidemiology, and recently, spatial epidemiology. My modest achievements at the international and national scale. Mr. Vice Chancellor, sir, apart from my academic work of over 100 published articles in peer-reviewed journals, I have had the opportunity to interface with the TB and HIV programs at national, state, and local government levels. It gives me practical experience in seeing the challenges of programming in the real world. I was involved in national assignments, which included developing, implementing, and evaluating national policies and programs. Some of my contributions include the following. I was a team lead in multiple national surveys for the Southwest Zone. This includes the first national TB prevalence survey, the first national drug-resistant TB survey in Nigeria, the first national quality of care survey, the first WHO catastrophic cost survey, the first national TB CAP survey, and other national surveys. Now let me go to acknowledgements. Well, I want to thank every one of you that have been here. I thank the DC, I thank all the principal officers, I thank my parents, I thank my in-laws, I thank my provost, College of College of Health Sciences, I thank my mentor, Professor Kamil Olausa, for being here personally. And I want to thank all my spiritual fathers and everybody that have been here. The CMD, the CMAC, and every members that are here and those that are watching online. To my beloved children, to Oluwanimi, Oluwadamilola, and Oluwatobi, I want to say thank you for making Daddy proud always. God will continue to bless and lift him up high. I want to appreciate my wife. And my friend, Dr. Bolani Dr. But without you, my life would not have been complete, and my dreams
what I've accomplished. Your love, support, and encouragement made all the difference in the world. Thank you for being there now, and thank you for being there always. Thank you all for your attention. The devil meant it for evil, but God turned it around for my good. Thank you very much.
Distinguished ladies and gentlemen, can we give a standing ovation to the standing? Thank you very much. Thank you. You may have your seats, please. Thank you. And thank you very much indeed. For unique people, unique events, unique things happen. For today, we thank God for everything, and it shows that He's a conqueror today. And once again, on behalf of the Vice Chancellor, management, staff, students, and the entire university community, I want to thank you all, distinguished ladies and gentlemen, for making today's event for real. And for those things that have happened, it only shows that God is in control. And God is indeed in control. We thank members of the Daniels family, far and near. We thank you for coming. We appreciate you for coming to Ankowe. We won't end this program without recognizing someone that I know that Professor Daniel himself will have taken time to introduce. There's one of our distinguished retired scholars here, who is actually a mentor to Professor Daniel. He was once the provost of the College of Medicine. He had also been the chief medical director of the teaching hospital. He has also been the registrar of the National Medical Postgraduate College. He has, of course, been a deputy vice chancellor in this university. I am indeed pleased to introduce Professor Olani Tamara Alausa. You're welcome, sir. Thank you very much, sir. It's good to see you again after so many years. We welcome you back to the university. All of you here, you are all very important today. We thank you for coming here. You have all witnessed God at work this afternoon, and God will continue to be at work with us all through the year. So thank you very much for coming. Shortly, I'm going to ask the Vice Chancellor to declare this ceremony closed. Please, if you can, while the procession is exiting, please stand and remain standing while the procession exits. The immediate family, I mean the wife and the son, will follow the procession to take some photographs immediately, and other members of the family can join them outside. Once again, we thank you very much for coming. May I now invite the Vice Chancellor to please declare this ceremony, indeed an auspicious one, closed. Thank you.
Let me recognize the CMD. I can see on my left hand side the CMD and the Mr. CMD as well. Dr. and Dr. Mrs. Mandaj. And I can also recognize the speaker, other distinguished personnel here present. Although the registrar recognized Professor Amarudin, who also happened to be my mentor, and I'm not for the profession as well. Ladies and gentlemen, maybe you want to go to Institute of Governance, you know. It's not very difficult to start talking about politics. You told me how politics is, so don't happen to politics. As far as the better politics, you can see the action. So when he was actually talking about the epidemiology, you hold the action that time. By the time you move to money, I can see started drinking water. So by the time you get to the issue of politics, God is in control. Ladies and gentlemen, we have all all listening to this wonderful lecture, and God did not allow Satan to take over the good deed of what you have done. On behalf of Senate of this university, I hereby declare 106 Inaugural Lecture closed.
Can we please rise, please? Thank you very much.
The procession is now moving out of the hall in a fast order. The members of the family should please join the procession. Thank you very much. The members of the family are expected to join the procession. Other members of the family will need to wait for the procession to move out of the show hall. Your event is at your various destination.